From Rhode Island Public Radio and the Rhode Island Public Health Institute, this is Hepatitis C, Cost, Cure, and Challenge. We are broadcasting live on the campus of Brown University. I'm your host, Kristen Gourlay. We are talking about the high cost of hepatitis C in human lives, in suffering, in healthcare dollars. And I am joined now by Dr. Lynn Taylor. Dr. Taylor is an infectious disease specialist with the Miriam Hospital, and she teaches also at Brown University, and she's been helping patients battle hepatitis C and other infectious diseases for many years. And recently, she decided to marshal a really diverse group of people, group of resources to help in that battle. And she started an organization called RI Defeats Hep C. Dr. Taylor, welcome.
Thank you.
Tell us what you're trying to do with RI Defeats Hep C.
So first of all, thank you for the privilege of joining in tonight. And I want to thank John and Letitia Carter and the Rhode Island Foundation for the Rhode Island Innovation Fellowship, Rhode Island Defeats Hep C, and acknowledge my many partners at the Miriam Hospital and Brown University, all the physicians, Dr. Megan Pinkston Camp, Dr. Karen Tashima, Tim Flanagan, many others, our nurse Sheila Tamilty, who I see here, our wonderful community collaborators, Paul Fitzgerald, Ray Joseph, at AIDS Care Ocean State, because it's imperative that any discussion about Hep C is focused on community. And I see Sophie Spreck-Walsh, our nurse at Kodak, and Dr. Pelagian, our methadone program, who are focused on evaluating and caring for Hep C. So I do have to thank all these people, and I see Dr. Brandon Marshall, our epidemiologist, who helped us come up with our estimate of 16,000 individuals infected with Hep C in Rhode Island. And I appreciate what we've discussed tonight, but I do want to reframe this a little bit. I don't want anyone in the audience or listening in to think that the crisis in Rhode Island and the crisis in America is about incident or new Hep C infections. That's a problem. And Jonathan, I'm so respectful and appreciative of your story and what you shared, and I see young people with new Hep C infections every day. But the crisis is about people in their 40s, 50s, 60s, and beyond who are dying right now, calling, crying, dying, while the carrot of curative safe therapy is hanging there. We're talking about double digits of new infections versus tens of thousands of Rhode Islanders who dabbled in injection drugs or intranasal drug use. Remember, this infection can be acquired through snorting cocaine once in the 80s in New York. Maybe you went to Woodstock. Maybe you went to party in college. We're not talking about primarily people who are currently struggling with injection drug use. This is one or two times years ago, and now we have grandmas and grandpas, breadwinners, caretakers, parents, physicians, judges, people in all kinds of fields who are stuck now with the very high risk of illness, suffering, death that is all could be averted and avoided with access to curative therapy. So please just know we're talking about a baby boomer crisis. People born between 1945 and 1965. That's the urgency.
Okay. Very important to note. And just tell us briefly, what are you trying to do with RI Defeats Hep C? What are some of your main goals?
We really, between our beautiful health department and our public health institute and our public health schools and Dr. Seepy and all the wonderful medical institutions, I see Dr. Alexander, we really are a state, I feel so optimistic, that could be the first to eliminate hepatitis C with a coordinated, proactive effort. And we have many different goals. One is to focus on high-risk populations with on-site integrated care, not trying to take individuals and navigate them through a whole continuum, through locale to locale, from step to step over years and months, but go to places where there's a lot of disease. So that's why I work with Sophie, where Dr. Pelagian began the process at Kodak, Rhode Island's nonprofit methadone maintenance program, and we see and care for patients right there and make it very easy. That's why I work with Sheila Tamilty at our HIV care center at the Miriam Hospital under Dr. Timothy Flanagan, and we eliminate Hep C among our 500 patients there. And that's why we are so fortunate to have Dr. Pashkas, and we want to focus on corrections. We want to give a shout out to our incredible VA. The Veterans Administration is the largest provider of Hep C care in the United States. And we have an incredible VA program headed by Dr. Promrat, Dr. Lally, Dr. Gaetanis. We want to eliminate Hep C in our VA. And hey, there's a bipartisan issue if you've ever heard of one. Get more money to cure the veterans. That's something everybody can agree upon. So we want to focus on the places where we have a lot of people concentrated with Hep C in the shortest amount of time, cure as many people at that locales as possible. The idea of navigating people through hundreds of steps is based on the HIV care model, which is based on having federal funding. There's no federal Hep C support.
We're going to talk about that in just a moment, but also briefly, I know one of your goals is to get more people screened, because you can't treat someone unless you know their status, right? So for people who haven't been steeped in this like you are, why hasn't this been such a priority? Why isn't it just part of a regular doctor's office visit to get screened for hepatitis C?
So many reasons, and I think Dr. Seepy spoke to some of this. First of all, Hep C is a silent illness. If we all injected me right now with Hep C, I'd probably feel nothing. So we have no idea when we've acquired Hep C. We feel nothing. When people say, I turned yellow, I went to the emergency room, that wasn't Hep C, that was hepatitis B. So we don't feel anything, we catch it, we won't know that we have it unless we get a test. And how many physicians in this room learned about Hep C in med school? I think we got 1 minute in medical school. It wasn't an issue. It was a very unpopular disease. It was thought to be unimportant. It was thought to be not curable. It was thought to occur among people who were less important, which of course is egregious, even to speak those words out loud. And so it's really now that we have this crisis with this wave of the baby boomers aging that the CDC and others are starting to realize that we have terrible years ahead if we don't intervene immediately. We have, in the next 1, 3, 5, 10, 15, 20 years, we're going to be taking people out with tremendous suffering at the prime of their lives. And so all of this is coming together with the World Health Organization and the CDC, and we now have simple testing that we can do. And here's the key: automatic reminders through an electronic medical record. All of you tech-savvy people know a lot more about this than I do, but what we have are electronic medical records. We should be the first state in the country to cover our entire state medical community with an electronic medical record prompt to say, hey, baby boomers, get screened for hepatitis C. You don't remember what you did in 1960. Maybe you snorted cocaine once. It doesn't even matter. It just matters if you were around and a teenager or in your 20s or 30s. Get tested. Most people say, how did I get this? I don't even know. And so I'm very appreciative of Lifespan, the largest health provider in the state. On April 1st, when they go live with their new electronic medical record system, we're going to be having pop-up reminders to screen baby boomers, and we really need the whole state to be doing this.
Great. You're listening to Hepatitis C, Cost, Cure, and Challenge on Rhode Island Public Radio. We are broadcasting live from Brown University. I'm your host, Kristen Gourlay. We're talking with Dr. Lynn Taylor here, and I want to bring Dr. Amy Nun into the conversation. She heads the Rhode Island Public Health Institute. Welcome, Amy.
Thank you.
So you may have heard before that Lynn Taylor and other doctors like her are having a tough time getting these the new medications, the new treatments for hepatitis C that are out there. They're having a tough time getting them for their patients. And it's heartbreaking to have to tell a patient to wait. I've spoken with Lynn Taylor about this many times before. But insurers and public payers like Medicaid are in a tough position, right? They can't afford these drugs for everyone who needs them right now. Rhode Island's Medicaid program is already in the red, primarily because of hepatitis C treatments. So something has got to give. What is it?
Well, I think we're going to have to spend more on this public health crisis. That's the bottom line. But I think we also need to think about how we can shift the business model. Currently, we're working within the confines of a high margin, low volume model. What does that mean? That means that the drugs are very expensive and we're providing them to very few people. With those same amount of resources, if we were to move to a low margin, high volume model, we could cure a lot more people. How does that happen? Social progress over time. This is not a problem that's going to go away. But we have lessons from history. We know that this worked for AIDS treatment. I want to remind everyone in 2000, our government's policy was that we were not going to spend monies on antiretroviral drugs to treat people in Africa. Our policy was that we were going to let those people die because it was not cost effective. What happened? George Bush introduced the President's Emergency Plan for AIDS relief, and we started scaling up treatment to millions of people across the developing world. Now about 10 million people in developing countries are on AIDS treatment. We went from a high margin, low volume model to a high volume, low margin model by working with the private sector to develop innovative strategies. We also decided we were going to spend money on this issue. Back then, we said that it was too expensive to treat people because it cost $10,000 per patient per year to treat people living with AIDS. And it was a human rights crisis to say it was too expensive. Well, activists held us accountable, and they also worked with governments to try to develop innovative strategies. And as a result, The cost of AIDS treatment in developing countries now is less than $100 per patient per year because government and industry got together in the same room and figured out how to work out this problem. And we're going to have to do that with this disease. There's no way around it.
But the easiest solution, right, is just lower the drug prices. These are very cheap drugs to manufacture. What are they paying? $1 a day in Egypt? $100 a day in countries with universal health care. We in the United States are bearing the cost of drug development, and the prices are the highest here. Why? Because it's a free-for-all and a business model, and there's no regulation and no pressure. We're here to pressure the drug companies. We wouldn't be here if the prices went down, which they could. That's the first step. Lower the drug prices. You'll garner more support for treatment, and we'll treat more people, and you'll still make the same profits. It's not Medicaid's fault.
Right. There are so many parallels, I think, between HIV and AIDS and hepatitis C. Could we just explore this a little bit more? Amy Nun, there was a time when we didn't know the extent of the HIV epidemic. We didn't know, people couldn't get treatment. It took a social movement. What are some of the parallels? What are some of the differences in this particular case?
I think the biggest difference with the social movements is that this was something that impacted affluent white men. And also, we had drugs to treat people that they demanded be developed by both our government and our industry, and a social movement is lacking. So the reason that we wanted to put this event together was to help garner support among the millions of baby boomers across the country and the thousands of people in Rhode Island that have hepatitis C and may not even know it, or may not know that they can take one pill once a day and get cured, to really pressure our governments and the pharmaceutical industry to do something about this crisis. One of the things that we have to do to move that business model and to change it is to increase screening, because a lot of people don't know that they're infected. If we increase the number of people who know their status, then we can change that business model. But it all really starts with prevention and with screening. And I agree with what Dr. Taylor said about increasing screening and routine during the course of routine clinical care. That's an easy and inexpensive way to screen people to scale. And it's something that we're working really hard together on to see if we can move this needle in Rhode Island.
There's another funding issue that you raise, though. I mean, there's the cost of the new drugs to treat hepatitis C, no doubt. But there's also the cost of prevention, education, screening, and there's such a huge disparity between the funding for HIV and AIDS prevention and screening and money available from federal and state sources for hepatitis C prevention, screening, education. Your thoughts?
I think that's one reason is because we don't have a social movement. Perhaps one reason we haven't had a social movement around this is because there haven't been great treatment options available. So now that there are treatment options available, I think that we really need to rally support around that. The other thing is we may need a Ryan White lookalike program. For those of you who don't know what the Ryan White program is, it's a payer of last resort to pay for treatment, care, and medications for people living with HIV. The magnitude of this problem is so much bigger, I would posit that this may require a federal solution. We may need a Ryan White lookalike program for hepatitis C, and it's something that a lot of us are getting involved in the advocacy world, and Dr. Taylor in particular has been really vocal about this. And I think it's something that we really ought to put on the table, both at the federal level and at the state level. The alternative is that all of these people, I want to remind everyone, are going to age into Medicare. So it's pay now or pay later. And the longer we wait, the more expensive it's going to be. And the taxpayer is going to have to foot the bill in either case. So I would argue that it's cheaper to pay people now and work on changing this business model so that we can really attack this now while it's cheaper.
So we need a plan to do that, and I want to talk a little bit about some of your work, both of you. You've started, you're heading up the, Amy Nun, the statewide Hepatitis C Action Coalition. So this is a group of people from all across the state in different fields who've come together. Dr. Taylor is a part of this, and you are developing a state plan right now, or embarking on this project to fight hepatitis C. Lynn Taylor, what should be in the plan? And we only
First
have
of
a few
all,
minutes.
a focus, a commitment to keeping Hep C front and center in Rhode Island, and a commitment to moving fast, and a commitment to working to make sure that the existing healthcare disparities that exist are not sharpened by the epidemic and deciding there are haves and have-nots, and focusing on the crisis among the patients, the older patients with the more advanced disease, in whom we could prevent this, again, this impending disaster of premature death. I also think that's what's very important right now is that we include a focus on Medicaid. And yes, Medicaid is in a very tough situation. They only have a certain budget they have, but I'm concerned that the current Medicaid situation in terms of the Hep C medications is not only discriminatory and disrespectful, but it's illegal. And I'm not a lawyer, but I'm working with lawyers, and I think we should have another forum and bring some lawyers in to address the issue of whether Medicaid in Rhode Island or any other state is allowed to take drugs that are approved by the FDA for people with chronic hepatitis C of all stages and say we're only going to use it for people with this stage. Or even to question about substance use in any way. There should be no reference to alcohol use, injection drug use, prior drug use. It's not medically relevant in terms of Medicaid policy. So we have to have a focus on having a transparent, open process, open to the public, easily accessible, that Rhode Islanders can weigh in on. That's a living document that moves quickly over time.
And Dr. Taylor's talking about the questions that are asked on a pre-authorization form. That's what insurance companies use to determine whether or not you'll get approved for a drug. And one of those has to do with your current substance abuse status. Amy Nun, what should be in the plan?
Bulk purchase agreements. I think we need to negotiate with drug companies much cheaper prices, and we can do that by committing to treat certain numbers of people. This is not just a solution in Rhode Island. The VA does it. If the VA is doing it now, why can't we do this across the nation? I think that Medicaid plans across the country can and should, and my understanding is they are trying to engage in bulk purchase agreements so that there is an agreement in place that would allow drug companies to dramatically reduce their prices in exchange for committing to large purchases. There was today, it was announced that the AIDS Drug Assistance Program engaged in a huge bulk purchase with AbbVie Pharmaceuticals. I think this is a great model, and it's something we can learn a lot from, and I think it's something that we should take to scale with the other drug companies, because increasingly more products are going to be released to the marketplace, and we can only create a virtuous public health cycle if we start screening and treating people. If we just wait and we fight about the prices indefinitely, then people aren't going to get cured. We've got to have some really tough conversations between government and industry, and we need to get advocates involved in this too. And to shine a bright light on this is a crisis. It can't be just a beating up on Medicaid about their refusal to treat, and it can't be just beating up pharmaceutical companies about their high prices. They've got to come together and agree that we can do this better.
And we are going to have to leave it there. There's so much more to talk about, but that's all the time we have right now. I want to thank Dr. Lynn Taylor, Dr. Amy Nun for being here. That is it for this special hour, this special forum on hepatitis C on Rhode Island Public Radio. Thank you for listening. Thank you for watching. And thank you to our live audience here. I want to thank all of our guests for being here tonight. And a very big thank you to everyone at the Rhode Island Public Health Institute, the Brown School of Public Health, and Brown University for making this event happen, especially our technical folks in the back. Thanks also to our engineer, Aaron Reed, and our news director, Catherine Welch. Rhode Island Public Radio's reporting on hepatitis C was supported by the Annenberg School and the Rhode Island Foundation. Thanks very much. I'm Kristen Gourlay.